Hi, my name is Adam Phillips. I'm a cardiology fellow at Beth Israel Deaconess Medical Center. We are here at ESC2019, and I'm joined by Dr. Montalescot, the PI of the Adrift study, which was presented just this morning. So, Dr. Montalescot, tell me, what was this study all about? What's the background of it? What were the questions you were trying to answer?
So the question is about AFib patients undergoing an implantation of these devices that we put in the left atrial appendage, because most of the times they have definite contraindication to anticoagulation. So they cannot get usual treatment of AFib for the prevention of stroke. We close the left atrial appendage. But the next question, of course, which has not been evaluated at all, is what is the optimal antithrombotic treatment once you have done this, knowing that this is, of course, AFib patients. Very frequently they have a prior history of stroke, they have a prior history of bleeding. In Europe, most of the patients are closed for the left atrial appendage because of a definite contraindication to anticoagulation. They have big left atrium with blood stasis, and you put a device in the middle and you fear device thrombosis. So what many physicians do, and we have this evolution registry, for example, telling us what they do, they use dual antiplatelet therapy with suspend and clopidogrel, which is something that is perfectly adapted to stenting, but probably not to this procedure. So what we decided to do is to test another strategy, probably at a low risk of bleeding, single therapy, with anticoagulation, but a low dose of anticoagulation, with one of these new drugs, an NOAC, versus the APT. And we did a randomized study, which is a small randomized study, feasibility study, looking at the biological effect of these drugs to start with, and make sure that even with a reduced dose of rivaroxaban, in this case, 10 milligrams or 15 milligrams, we have an effect, biologically speaking, on thrombin generation versus the APT. So this is what we did. We randomized 105 patients in a small multi-center trial. We measured thrombin generation, prothrombin fragments 1+2 at 10 days, 2 to 4 hours after drug intake. So when all these drugs are effective, and indeed the primary objective was significantly reduced, so prothrombin fragments 1+2, much lower with both doses of rivaroxaban than with the APT.
And did you look at clinical endpoints as well?
We did. We looked at clinical endpoints. It's a small study. It's not powered for clinical endpoints. Most of these endpoints actually are bleedings. No difference really between the three arms. And the need clinical benefit roughly is the same. We looked very carefully with a core lab which was blinded to treatment, to all these images we got at 3 months, CT scans, TOE, and we looked at device thrombosis. And actually, in this trial, we had 2 device thrombosis in 2 patients.
As determined by?
As determined by either a CT scan, a TOE, or both.
Okay.
And these 2 device thrombosis occurred in 2 patients on the APT. So suggesting that indeed, we may have what we are looking for, which is better efficacy with some degree of anticoagulation rather than with the APT in these patients. So it's the first study of this type. There is no other study like this. I'm not aware of any other ongoing study, randomized study in the field. What we need now, obviously, is a phase 3 study.
And it's such an important issue. Just this past week, I had a patient who had this kind of device put in, and they were high bleeding risk, and they were on an anticoagulant as well as aspirin, and they started bleeding again. And these are really high-risk patients, and we don't have good evidence to guide what to do with them.
No, and every physician takes the best decision that he can take, but sometimes it's aspirin alone, sometimes it's clopidogrel alone, sometimes it's dual antiplatelet therapy. Sometimes now it's a NOAC, low dose, reduced dose, but nobody knows. And we need some strong evidence to guide the practitioners.
And so how will this trial guide your practice?
I think the idea is that we have now at least some data saying it's feasible, it's doable. Look, we have done it in a number of patients here. And if you want to use this strategy, at least it has been done before in a clinical trial, which is too small, obviously, but we have some data. Now, it's not perfect, but I know already that in this country, patients are treated with low-dose NOACs after left atrial appendage closure without data.
And for how long?
Usually 3 months.
Right.
And this is a period where the device is not covered yet, and the healing time takes probably 3 months, and after that we stop it.
Do you use any imaging to guide your decision about whether to stop it or when to stop it?
We do use imaging at 3 months, a CT scan or a TOE, or sometimes both, just to make sure that there is no big leak around the device and no thrombosis on the device. And if this is the case in these patients with a contraindication to anticoagulants, we stop the treatment.
But that wasn't part of this trial, or
no,
it wasn't decided whether to continue or stop based on.
No. It's not the trial we did.
And so, what's your take-home message for the audience here?
I think what I would like to do is to change the mindset of interventional cardiologists, thinking that the APT is good for everything. Stents in the coronaries and a device in the left atrial appendage, in a fibrillant atrium, big like this, with contrast in the middle, blood stasis. It's not the same disease. It's not the same type of prevention that we need. And just think that a low level of anticoagulation may be better than the APT. It's feasible now, and what we know from big trials is that at least in AVROS, for example, the safety of one of these NOAC, apixaban versus aspirin, was the same. So here we use a NOAC at a lower dose, so I would expect the safety at least like aspirin, maybe better. And keep in mind that when you use DAPT, we have another study, Active W, showing that DAPT has the same safety as warfarin, and these patients are contraindicated for warfarin. So
we need to tailor the individual therapy to the individual patient who has a specific kind of device.
Absolutely.
Absolutely. We hear it again and again. Here from ESC 2019, thanks so much for joining us.
My pleasure.